let's go prostate.
All right. Let's
And
go.
really three conditions that we see a lot of. I tend to do a PSA on everybody just because so many men have not had prostate done, even though it's not part of the metabolic syndrome directly, although I would argue it might be. We do PSAs on everybody. So let's just start with PSA. And
Mhm.
from what I've seen, most doctors don't worry about a PSA of four, under
Yeah.
four. What are your, when you're exclusively looking at PSA, what should somebody be concerned about? Where do you say, don't worry? Where do you say, okay, let's work this thing up? What is your feeling about PSA as a screen and what should be done about different numbers?
I usually start if the patient is willing at age 55, and we'll say 55 to 69. Definitely, I'm going to recommend that they get, their PSA, which is a prostate cancer screening test. It doesn't mean, I tell folks, it doesn't mean you have prostate cancer. It's a it's a marker, or it would clue us into the possibility. So honestly, if it's less than four, I'm just not worried about it. I've never seen a prostate cancer from somebody less than with a PSA less than four. There will be urologists out there who will say they have seen one less than four, but they're very few and far between. And I've definitely, I would say, never what I would call a bad one. We call them good and bad prostate cancers. Um, but 55 to 69, I would definitely recommend. If somebody's on, then we can get into testosterone at some point if you want. But if they're on testosterone, we'll monitor their PSA at least every 6 months while they're on that. And as far as worrying, it would be great if PSA was like a yes or no type of positive, negative type of test, but it's not. And so we look at the number, we look at what's called the PSA velocity, we look at the PSA doubling time, we look at free and total PSA, and I usually just have a conversation, with people and say, okay, look, this and this and this shows if I did a biopsy, there's a 55% chance that there's prostate cancer, or there's a 5% chance. You tell me what do you want to do? Their options being proceed to that next step, which would be a prostate biopsy, or let's just monitor that PSA and say that as long as that number doesn't change much, that we're just going to keep watching it.
So at what level would you consider biopsy? At what PSA would you consider biopsy?
Anything above four. Now, if let's say they're 72, let's say they're 70 and it's less than five, I'm probably going to say, nah, if you're my dad, brother, grandfather, just watch it if I were you. Um, but yeah, I have seen some bad cancers that the PSA is, and it was an early pickup, but PSA is somewhere around 4 or 5. But that's not all of them. That's, just a few.
You mentioned velocity because we tend to get baseline PSAs fairly routinely on even on people slightly younger than 55. And I've
Right.
got one patient in particular, now it's an anecdote, who went from a 0.35 to I think it was close to 3 in
Hmm.
a very short period of time and ended up having a prostate cancer. So most of the time the GP would have said, you know what, don't worry until you're 4. But that velocity, so I'm intrigued that you mentioned velocity as one of those tools, which he would never have gotten screened. And yet, in the time that we did that, it did go up a lot. He was recommended by me to go and see somebody, and they found something. So
Yeah. Yeah.
go ahead.
So I think that that's a reasonable, like if I had that patient in the office and it was like point 0.3, point 0.4, point 0.3, 3.2, and we repeated and it was 3.2, then I think it's reasonable to, do a biopsy at that point. That is a decent jump because you're looking at the trajectory, but you're also looking at where did it start? So like that's more concerning than if it was, let's say 11 and then made the same jump to 13 point something or 14. That's not as big a jump in the urologist's head as a zero point 0.3 to a 3.2, if that makes
Right,
sense.
right, absolutely. So I know this may be a naive question, but there's so much confusion about three words that I'm going to use. And then I want to come back to prostate cancer. But we've got
Okay.
prostate cancer, PSA prostate cancer. We've got prostatic hypertrophy, uh,
Uh-huh.
particularly when it's symptomatic about urine. And then we've got prostatitis or infection or
Yep.
inflammation of the prostate. Can you tease those three out, help people
Sure.
to understand what the three terms mean and how you would manage each of those three? And I want to come back to the more detail, especially with some information that's come out recently about prostate cancer and being
Okay.
more conservative. I want to discuss some of that with you.
Sure. So we talked about the prostate cancer part. Prostate hypertrophy, or you also see BPH or benign prostatic hyperplasia, is just, we'll say, larger growth of the prostate itself. And prostatitis is like a low-grade infection that you can get in the prostate, and you don't even have to be symptomatic for that. But it's interesting that you mentioned those three things, because those are the three things that make that PSA number change. So prostate cancer makes it change. Having a bigger prostate than most guys your age would change it, or having prostatitis, which we'll just simply call like inflammation of the prostate.
Is it usually infection or inflammation?
Um, it's infection. So again, you could be asymptomatic. I've actually had prostatitis twice. It was pretty easy to treat, but I know what it feels like now. And it's something where, and you can actually see this in some younger guys. So interestingly, you're talking about screening somebody who's young. I had somebody who was referred to me recently who had moved to town, had been to another urologist in a different city for prostatitis, and he was like 47 and had his PSA checked, and it was high. I mean, pretty high for us. Um, but it quickly came down with treatment for the prostatitis, and he had no family history, and it stayed normal. So, we said, let's not do a biopsy unless we really feel like we have to.
How often do you do ultrasounds? Do you find, is there a benefit to a prostatic ultrasound? What is your modality of imaging for the prostate?
So this is where I'm going to differ from some of what people would currently say. So I will do what's called a 12 core biopsy. So if you're looking at the prostate and it's a big old apple, we'll say BPH, or the area where the prostate grows and can cause some trouble peeing, is on the inside. It's the mucilage, or it's the meat that we eat. Prostate cancer almost always is on the perimeters or the outside edges of the prostate on both sides.
The prostate, let me just, prostate cancer is probably then less symptomatic.
Right,
So if your PSA is high and you've got no symptoms versus if you can't pee and you've got an elevated PSA.
right. But you can also, interestingly, you can have a huge prostate and not have any trouble peeing. So that kind of gets, a little intriguing, I guess. But totally blanked on your question before that. What were we
So no,
talking about?
you were talking about yeah, we it's that time.
Yeah.
Um, you were talking about imaging,
So imaging.
and you
Okay.
were doing
So
the 12 core biopsies.
yeah. So what most urologists will say these days, and I think there's a fair argument for it, is a lot of times they'll do what's called a MRI guided prostate biopsy. They'll do an MRI and they'll see a spot, and then they will go after that specific spot with their biopsy. I feel very comfortable that my what today would be considered old school, but wasn't 10 years ago, 12 core biopsy is going to cover everywhere that prostate cancer can probably hide, because I know where it should be when I'm looking on an ultrasound, which is how I then, actually do the biopsy. And personally, I just think it's a lot more cost for what you can get out of it, when I think you can get the same result a lot cheaper. But that's just me. So I
Oh, so
use
an
ultrasound.
ultrasound guided biopsy as opposed to an MRI guided biopsy.
Correct. That's right.
What other imaging modalities, if any, are recommended?
That's for when you're looking for prostate cancer, or you have any concern related to that. Those are the two main. I mean, that's what almost everybody. It's either ultrasound or MRI guided biopsy. Those are the two things I think just about everybody uses.
So in the modern era, how good is a GP's finger?
Uh, Not good. So this is another interesting thing. So I don't do digital rectal exams unless a patient really, 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 really wants one. And the reason is, with the PSA, I feel like I can make a decision with the PSA, and I do not think that the rectal exam is going to change my decision making, if that makes sense. Now, if I got in a situation where I really was on the fence with the PSA, I might do a rectal exam, but that is these days very, very few and far between.
So let me, even as a highly experienced, highly skilled urologist,
Mm-hmm.
you don't believe that your finger is sensitive enough to feel disease, and yet every family doctor out there is sticking their finger in a guy's butt on a
Yeah,
regular basis, which is one of the reasons why a lot of people don't go to their doctor, because they're
yeah,
afraid of it. And yet
yeah.
the value of that test is very low relative to a blood test. Is that what you're saying?
Yeah, because I mean, I don't know if you've ever done, you probably have, at least in training, a rectal exam, and you're really, at best, unless your fingers are like this long, you're just feeling the tip of the iceberg. And I just, it's not, it doesn't, you know, it, I don't know. I think it's one of those things that was great before we had PSA, but I think it's going to continue to come into question as to its benefit, um, kind of the further we go.
Yeah, I mean, I trained in the early 80s, and I can see my professor of surgery turning over in his grave, because his big statement was, if you don't put your finger in, you put your foot in. But that was
Yeah.
before we had all of these imaging modalities, before we had, I mean, this is the 1980 to 85 kind of era when I was in medical school. So it's way back there. And I love what you just said there, because that has altered my thinking. I've always thought, as a surgeon, I do a lot of rectal work. I do a lot of rectal reconstruction, that kind of work. And putting my finger in, you can feel the sphincter very well. You can feel
Yeah.
around the sphincter, but you can't. I've always struggled to feel the prostate, and I've always pretended that I know what I'm doing, but I really haven't. And I've always not been comfortable with that as an exam. So you've just corroborated something that's taken me 30 years of doubt to overcome. I love that. So
Well, but I think it's kind of like the emperor's new clothes, or whatever that is, as far as like everybody says, you know, oh yeah, I can feel a blah blah blah, but like I mean, somebody at some point is going to say, nah, I don't know about that. And everybody is going to say, yeah, we agree. Like, this is crazy. I think you could probably feel 10 or 20, at best 20% of the prostate. And so, yeah, I don't, there are some better tests out there.
right, and that's the point, is that that's an uncomfortable by perception as well as by function test. It's uncomfortable both sides, for the doctor and for the patient. And if it doesn't yield good results, and we've got simple, easy, simpler tests to be done that are more accurate and more revealing, that is just, it just blew my mind. And I mean, that's why I love these talks, because even as
Yeah.
a physician, it changes my thinking, or corroborates some of my thinking. So that's absolutely wonderful. Now, there was a paper that came out recently that discussed more conservative observational treatment of prostatic cancer. And one of the common questions I ask my patients, because this is one of the purposes of eating our eating plan, I ask them, how old do you want to be when you die? And my objective is, without subtracting a lot, to get our patients to live to 100, which is certainly not inconceivable. We're now living into the 100, 110 era, very few people going over 110. And what we tend to do is, if we're going to live to 100, we subtract from that age by doing stupid things. You text while you're driving, you can suddenly subtract from that. So
Right.
if I'm going to live to 100, but I die because I failed to have aggressive prostate cancer treatment, we're talking about 30 years beyond the age of 70, not just the average age of 76. So along those lines, what is your recommendation for a healthy person, irrespective of age, in terms of, okay, I've got prostate cancer. How do you stage it? How do you grade it? What does your decision tree look like?
What I use is what's called the NCCN guidelines, so National Comprehensive Cancer Network guidelines. And it's a, if they have this and this and this, then, evidence-based medicine, these are the two best options, that kind of thing. And there's a lot of wiggle room as far as what we would call observation or active surveillance for prostate cancer. And so I would say at least 40% of my patients, that's an option that I can give them when we have that talk. And we can go through the risk and benefits of that. And so for me, what that would look like a lot of times is I'll start off with a PSA every 6 months, and then initially we'll do repeat prostate biopsy at a year, and we'll keep spacing that out if nothing changes. Like, let's say, and we haven't talked about this, but in prostate cancer, we have what's called a Gleason score. For lack of getting into it, let's just say it's 6. So if that number does not change and the volume doesn't change, then we may still continue to observe. Now, there are places like I have a colleague who works at Memorial Sloan Kettering in New York, and and a couple at Hopkins who they're even looking at, like Bal Carter, I'm thinking of, who they are going even like 3 years in between biopsies and just watching that PSA. So they're really kind of in a good way pushing the envelope of, what can you get away with.
And is the danger local disease, or is the danger metastasis? And what is there a predictable, right? Is there a predictable metastasis risk over time?
Well, so the interesting thing with prostate cancer, and I alluded to this earlier, is there's what I would call a good kind and a bad kind. And usually the good kind is slow growing and predictable. And the bad kind, sometimes, even as aggressively as we might screen, like, it will do whatever it wants whenever it wants, and so, and there are very few that all of a sudden go from good kind to magically they're bad kind. Usually, and the majority of what we see are what I would call the good kind, that are slow growing and predictable.
So here's a question for you. If you as a surgeon, okay, would you rather have to do a prostatectomy on a 70-year-old healthy guy with an early stage cancer, or an 85-year-old guy with aggressive tumor that is now much bigger than it was 5, 10 years ago?
So the good thing with, as far as like a caveat to that, is, you do have surgery as an option, but you also, a lot of times, evidence-based medicine wise, when you look at like 5-year like mortality data and things like that, your radiation is a really good option. And so, like, for example, we tend to be a little more aggressive on the surgery side for our younger guys, but statistically, the radiation would do the same as far as benefit for them. And we tend to move a little more towards radiation in our older guys because with radiation, they're going to bounce back a lot quicker. And if they have any complications, you're really looking at, we'll say 10 years, and which puts them at, in your example, 95. And even at that, for example, what I'll do is if they're going to have radiation, it's called Spacor, but there's a little gel, biodegradable gel that I can put in between the prostate and the rectum so that when they're getting the radiation now these days, that the rectum can be away from that, which is great.
So, if you are most aggressive, if you surgically remove the prostate with a non-metastasized lesion, is that curative, and what follow-up does that patient require?
We would consider it curative, and we would start, for example, checking a PSA every 3 months for a year, then 6 months for a year, and then once a year. And it may not go. So the prostate, unfortunately, is not like the finger where like this is the end of the finger. The prostate is ambiguous. And so sometimes you'll still have something that's putting off that PSA or prostate specific antigen. And so we'll watch that number. So sometimes it may not go to zero, but that's how we would monitor it afterwards.
And what is, if you had radiation as a therapy, what is your monitor? Does the monitoring change at all, or is it the same?
It's really the same. Now, one thing is your prostate number or PSA might not get all the way to zero or undetectable, but whatever that low is, like that's your number. That's what I tell patients. And as long as that number stays about the same, we don't mess with anything.
Okay. And what are the downsides for surgery? I'm speaking because I'm a surgeon.
Yeah.
What are the risks, and what are the percentage risks, assuming someone's experienced? And then if this was you sitting in there with a doctor, you've got a resectable tumor, what are the different types of operation, and what would you have done personally? Because there's different approaches to this with different risks. What are those risks, and what is the best operation to have done, in your opinion, if this was you?
Today, really robotic prostatectomy is from a surgery standpoint is the only and the best option. I mean, technically, you can do what we call open prostatectomy or taking it out a different way than that, but robotic prostatectomy has really replaced as really the only way to get it out, because we can actually doing surgery down in the pelvis before the robot was very hard because you couldn't get a good angle to see what you were doing. I mean, you know this, even with the rectum, and little stuff like the seminal vesicles or the nerves, which are important for erections and things like that. I mean, we couldn't see that stuff. But with the robot, we can, and we can actually move it away from the surgical field and stuff like that.
And there's no transurethral procedures that can be done?
Not for prostate cancer. I mean, technically, there are some other interesting things that are promising, like there's high intensity focused ultrasound or HIFU for specific lesions in the prostate. It takes a long time to do it, but it's showing some promise with stuff like that. But if you wanted just a one and done, a robotic prostatectomy is a really good way to go.
And the major issues are urethral injuries, and then nerve injuries, and the seminal vesicle injuries. Is that correct?
Well, so your two big things are going to be what do your erections look like after surgery, and what does your continence look like after surgery? So with erections, I tell people 70% of the time they're going to return to what they were baseline before surgery. 30% of the time they're not, and that's something we can work with. But I also tell people they're not going to be better than what they were before surgery, because if you don't, it's magic. Like if you don't tell people that, they're disappointed afterwards, even if they had erectile dysfunction before. And then the other is 95% of the time, your continence will return. 5% of the time, you will have trouble. Because if you think about it, what you're doing is you're taking a piece of the pipe out and you're hooking pieces back together. And so, sometimes it can cause a little trouble.
And does radiation reduce those risks?
They do reduce those risks, but then you get out to that 10-year mark and you may have trouble with erections, but it also could be that you're just 10 years older. And so then it's kind of hard to tell. And the other thing is, like, let's say that you have radiation and then you have trouble peeing down the road. From a surgeon standpoint, there's a fine line between me going in and if our audience, if they think about trouble peeing for guys like a clog in a drain, me unclogging things, but then also making you have issues with leakage because the radiation doesn't do a good job of keeping things closed, if that makes
I
sense.
think that's, yeah. I mean, as a surgeon, it's a battle that I have a lot with my oncologic colleagues, is that they love radiation before surgery. And I understand the rationale, but I much prefer to operate on a clean field. And
Yeah.
this
And then let it
dichotomy,
heal.
in fact, I'm
Yes, let
having
it
this
heal.
discussion with a patient of mine right now who's got an imminently resectable malignancy. But the oncologists want to radiate the guy for 3 months before we do an excisional surgery, because that's what they do. And they don't understand that I can excise the thing. And then if they radiate the field, they're going to get the same
Yeah.
effectiveness. It's a change in thinking.
Well, and then yours is not going to heal as well, with all that radiation.
Exactly.